right, good evening, everyone. It is exactly 7 p.m. And welcome to another installment of the EmPower Hour, where we take this 1 hour and we look at coronavirus, COVID-19, and us. How is it that this disease, as it's presented itself, how has it become just so deadly? And not just deadly, but deadly to a specific group of individuals. Of course, as we've looked at all the reports, we've seen where it has adversely, even though it's killed many, and that it has, but it's also adversely killed many in the African American community, and we're wondering why. Why is it impacting us in such a negative fashion? So we have experts here that will help us walk through what's going on with coronavirus. And again, I am so elated to have this esteemed panel here with us. Now, again, I'm going to be multitasking. As you can imagine, I'm serving as host, but I'm also having to make sure that we are admitting everyone, that I'm looking at and reading comments, because we're doing that as well. You'll see that we do have the chat available. Let me just make sure that the chat is available. And I do encourage everyone, just a second here. Yes. Okay, and I do encourage everyone to get to know one another in the chat area, as we try to make this a networking session as well. So it's a matter of all understanding the dialogue that we're going to be dealing with, but then make sure that you get to know some of the people who are like-minded, people who really want to wrap their minds behind what's going on with coronavirus. We have the experts who are here who will be presenting to us, but then make sure that you reach out to some of the individuals that you see in the forum itself. And we're looking forward to that. So with that, I want to go ahead and start things off. Many of you know me, or if you don't, I'm Mike Weaver, and I started public health in 1992. I received my MPH from the University of South Carolina and worked for Morehouse School of Medicine for a number of years, as a practitioner, and then decided I wanted to come back to school, return to school to become an academic, and went ahead and received my doctorate in public health from University of South Carolina in 2004, and have been teaching at different schools, and Temple University, University of South Florida, Morehouse School of Medicine, which is where I met one of our panelists who was here, as a matter of fact. And but it's brought us here, having worked in academia, having worked in the field as a practitioner, sort of knowing where the rubber meets the road. And all roads have led us to here in this point in time, and what a point in time it is. So I want to thank everybody who's here, all of the panelists, as well as all of the guests, and we will allow the guests to have conversation with the panelists. So what we're going to do, I'll be quiet, and we're going to go to each one of the panelists. I will introduce them, and they will take 2 to 3 minutes and give some opening remarks and exactly what their experience is with coronavirus, with COVID-19, coronavirus disease 19 that we're dealing with. It is, again, wreaking havoc on communities, all communities, but particularly communities of color, and particularly, Black folks, if we can be honest. So we're going to have that conversation tonight, and we appreciate everyone being here. So without any further ado, I want to start with, I'm just going to go randomly with, Dr. Tralonda Triplett. Dr. Triplett is an epidemiologist. She's there in Orlando, Florida, has been in Florida for some time, has always been community oriented. I mean, if you're talking about someone who's grassroots, that would be Dr. Triplett. And again, so she was there serving with the county for a while, and now she's running her Institute on Leadership. So without any further ado, I'd like to turn it over to Dr. Triplett. Can you please tell us a little bit more about yourself, and then tell us about what's happening in Florida in regard to this disease, COVID-19. Dr. Triplett.
Well, thank you, Dr. Weaver. It is just a pleasure to be in your presence this evening. I will not tell anybody in this room that you were my instructor many, many moons ago, which makes you eons older than I am. So we'll start with that. In any event, I completed my master's in public health from the University of Miami, go Canes, and completed my doctorate of epidemiology in 2012 from the University of Miami. I have been a public health practitioner and global health consultant. I'm celebrating 24 years just last week. So that means I started when I was 2. That is also my story, and I'm sticking with it. When you talk about a place like Florida, though, one of the things that makes Florida so unique is just the tapestry and mosaic of different ethnicities. And when you say Black people in Florida, that can mean anybody. That can mean any ethnicity. That can mean any culture. And so living here, I get a bit cringe-worthy when I hear other scientists talk about African-American people, and that's not all you're talking about. Now, if that is what you mean, then let's go forward with that. But I am here, and my foot is definitely on the fact that race alone is not going to help us get to where we need to go. Now, it's nice to know as a preliminary step, but in order to address these issues and to move forward in these issues, we've got to disaggregate that information so that we know who we're talking about. So that's a 5-minute spiel on who I am and what I'm here to do. I'm so happy to be in the presence of all these esteemed colleagues, and I look forward to this conversation.
Thank you, Dr. Triplett. Thank you so much. Thank you so much. We're going to move over to Dr. Joe Saulsbury, who again is a family physician with WellStar Medicine, medical group here in Atlanta, in Stockbridge, Georgia. And Dr. Saulsbury is a Morehouse alum, like myself, and also Morehouse School of Medicine. Again, Dr. Saulsbury, introduce yourself and really tell us what's going on in your practice, if you don't mind.
Thank you, Dr. Weaver. I want to welcome all the distinguished panelists and guests who have logged on tonight. As Dr. Weaver just said, I'm Joe Saulsbury, the second MD. I am boarded in family medicine. I'm a diplomat at American Board of Family Medicine. I work for WellStar Hospital System here in Atlanta. I do urgent care medicine, so I've been on the front line for the past several weeks dealing with COVID-19. I've diagnosed several patients in the past several weeks. I've actually had several patients admitted for either bilateral pneumonia or ipsilateral pneumonia. And thus far, those individuals have come out fine. And as a caveat, before I move forward, those individuals were Black Americans like ourselves. So to Dr. Triplett's point and Dr. Weaver's point coming into this evening, this is actually impacting the Black community at a serious pace. Just briefly, I want to share some numbers. These numbers come from Johns Hopkins. On a global standpoint, there have been 1.5 million people who've actually been confirmed with COVID-19. And we've had, as of today at 4 p.m., 94,000 people in the world who've died from COVID. Just here in Atlanta and Georgia, Georgia has 10,566 cases as of today, with 379 deaths. Just the United States alone, total number of people who've been confirmed is 456,000. And we've had right now 16,000 deaths. And these numbers go up. And, last week when we convened last Monday, there was no talk of COVID-19 and the impact of what it's doing to the Black community. And here we are now, just 10 days later, and it's decimating places like Chicago, Detroit, New Orleans, now Philadelphia. So, we have to figure out what is the impetus as why we are so impacted in such a negative way. So with that, I'll turn it back over to Dr. Weaver.
Dr. Saulsbury, we're looking forward to hearing more commentary from you this evening. Thank you so much. I want to go to Dr. Jasmine Ward, again, who's there in Arlington, Texas. As you can imagine, as we put together these panels, we try to reach to different places, different quadrants, different regions of the United States. And Dr. Ward is right there in Arlington, Texas. Again, she has Black Ladies in Public Health. Dr. Ward, can you please tell us what you're doing there in Arlington, Texas?
Sure. I am so excited to hear from each of you. Honestly, this is an esteemed panel if I've ever heard of one. And so I am excited to be here to be able to share kind of what we've been doing in Black Ladies in Public Health. So just a little backstory. I am the founder of Black Ladies in Public Health. We are a network a organization that has been formed really through just, it's a grassroots kind of effort of getting to know one another that are in the field, studying for public health, professionals in public health, and those that come by way of experiences and interests. I say some are called, some apply. So we are really working towards galvanizing our community of experts in all kinds of subjects, really setting the bar higher for one another as it relates to ethical issues that we're now talking about in this moment, really. Thinking about ways in which we can support the profession of public health professionals. Our students, we've been hosting calls to really gauge some of the interest in supporting our students who are in this space, but also some of our members who are impacted and directly affected by COVID-19 in their work that they've been doing, but also having diagnosis. And so this is something that I think is evolving, just like, you know, Dr. Saulsbury said last week, we were talking about trying to obtain numbers. And I really appreciate what Dr. Triplett mentioned about the diversity of the diaspora and thinking about the ways in which we enter into a characteristic or check a box that we check and what that means for us. And for those of us who are shared space and with those individuals who can obtain a test because they qualify, but the people that are in the homes with them that cannot, what that means for individuals in terms of taking care of their children as Black women in public health doing this work. So we are really thinking about, you know, making decisions as to how we will move forward and really help prepare some of those individuals who are not at this point thinking about some of these things that people are making decisions about because they're not at the table, but we have to bring that to our awareness at a critical mass to say we demand that things are changing in ways that will not reinforce what we feel as a group of people, as groups of people who have been marginalized and discriminated against. And with where we stand right now, we can see that this is a, you know, exacerbation of what we already have been dealing with. I keep telling people, you know, people are asking me about all of a sudden this health disparity. And I'm like, no, it's been here. We've been doing this work. And this is important for us to recognize that we're going to go through this. We won't come out the same. We shouldn't come out the same. We should make sure that things change in ways that will support better health for all of us as we move forward. So thank you so much again. I am super excited to be here with you all. This is an opportunity really to think about ways that you know, we can consider and center the practitioners as well as the people that are in our communities that may not receive messages from the individuals who are giving it. And so it's up to us to really figure out how to do that.
Thank you, Dr. Ward, and you hit the nail on the head. That is our task, that is our responsibility, to make sure that we're able to put the message out to the community best we can. There's a lot of misinformation, to say the least, that's out there. And so we need to have these type of forums so that we can engage with the public can engage with experts so we can get the accurate information to the masses. So that's why we know what we're doing here is God-led, and we really appreciate that. We're gonna move over to our other panelists, our last panelist, to say the least. Dr. David Williams, who is chair of social and behavioral sciences, behavioral and social sciences at Harvard University at the Chan School of Public Health. And if any of you, Dr. Ward, said a moment ago how disparities is nothing new. If any of you have taught from this book right here, Unequal Treatment, which I have, Dr. Williams is one of the academic resources for this book. Again, this is by the Institutes of Medicine. This came out in 2003. So as Dr. Ward just mentioned, health disparities, health inequities is nothing new. And Dr. Williams has been on the forefront. You see how thick this book is. That's a lot of reading, right? And that's while I was, not only did I read it for my doctoral program, but I actually used it for a number of my courses when I was teaching at different schools. So again, without any further ado, I want to again thank Dr. Williams for being here and allowing him to speak on his research. And you will also see in the chat where I've uploaded a couple of articles that mention him just recently as today. So look at the chat, I'll put that information there. Please, Dr. Williams.
Sure. Dr. Weaver, thank you so much. And I'm honored to be here tonight too with the panel. And I am here because of the leadership that Dr. Weaver has played over the years. We've corresponded for many years. And I really want to support the effort to try to create forums where we can reach the community to provide education, to provide empowerment so that we can address not just the disparities in COVID-19, but the health disparities that are killing 200 African Americans prematurely every single day. If Black folk in this country had the health of white folks, 200 Black people who die each day wouldn't die. So coronavirus is just putting the light on a problem that exists, not just coronavirus, but in heart disease, in cancer, in stroke. African Americans are dying at a higher rate. And as we think, I just want to talk a little bit about the economic context that I think we need to keep in mind. One of the reasons, it's not the only one, racism is a factor too, but one of the reasons why the death rates are so much higher for African Americans is that African Americans are lower in economic status. I looked at data from the US Census Bureau for 2015, and in 2015, median household income for Black people in America was 59 cents for every dollar that whites earned. What is stunning about that is that it's identical to the racial gap in income in 1978. I did not misspeak. You heard me correctly. 1978, the peak year of the gains as a result of the civil rights movement and the anti-poverty policies of the 60s and 70s, the Black income had increased, so they were now earning 59 cents for every dollar. And in 2015, we still earning 59 cents for every dollar. And it's not that it's been stable at that level over time. Throughout the decade of the 80s, it fell from the 59 cents figure, and it was not until 1994 it came back up. Now, if you think that's bad, that data on the income gap understates the economic gap. What I mean by that, income captures the flow of resources into the household. It tells us nothing about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth. What are the assets? What are the economic reserves that Black folks have? And I looked at the latest data from the Federal Reserve Board. For every dollar of wealth that white households have in 2017, Black households have 10 cents and Latino households have 12 cents. So when we talk about the impact of coronavirus on the Black community, we have to realize the low economic status and how that shapes the risk factors for coronavirus. But we also need to keep in mind that when we are talking about a disproportionate number of African Americans and other people of color dying, we are looking at the losses of income streams within the African American community. There are fathers and mothers dying who were supporting children. There are persons dying who were supporting others within the community. And what I'm saying is the African American community does not have a cushion, does not have, when you don't have wealth, you are one paycheck away from being homeless. You're one paycheck away from being able to take care of your kids. So we really need to think about the economic impact. I need to think that we need to get stimulus dollars to those who need it most. I'm not saying corporations don't need help, because yes, businesses need help in this economy, but we also need to think of what it means for low-income households and people of color, that they are losing their sources of income as well, which will multiply the negative effects on the entire community. So that's kind of what I would love to say as my opening comments.
Well, Dr. Williams, if I can just engage you a little more, given those individuals who have to go to work and the risk that they're putting themselves and their families in by having to go to work, having to support their families, and yet, you know, in some instances, not being able to wear protective gear. How do you think that's going to, I mean, if you could be clairvoyant, if you could look into your crystal ball, what do you think that's going to, how is that going to impact our community?
I think we can look, we don't even have to look into the crystal ball. I mean, the examples from Detroit of a bus driver who died as a result of coronavirus. And he talks about what was happening on his bus. And so part of what I'm saying is, one of the ways the low economic status is linked to what kinds of jobs we have. It's linked to what quality of education and preparation for higher education we get in our communities. What's the quality of schools? But it means that we are overrepresented in jobs that are essential, like in the transit system, in grocery stores, in management of buildings and apartment complexes. So we are in many jobs, overrepresented in many jobs that are low income, and that don't have the luxury. I'm working, my institution requires me to work from home. Not everybody can work remotely and work from home, because some people have to be on the front lines, and then some people just can't social distance in the ideal way when you live in a crowded housing unit with multi-generation, family context. So not everyone is positioned to do the protective things that we need to do to protect ourselves from the coronavirus.
Thank you for that. I want to give the panelists would any panelists like to make a comment before we actually open it up to everyone, because we want to be mindful of what this is all about. We want to make it an interactive session, but any panelists, would you like to add anything else? Dr. Triplett, I see would you like to mention anything?
I'm just saying I don't want to add anything else. You have capsulized not only the risk, but susceptibility that Black populations are experiencing at higher levels and higher rates. And certainly that is going to result in higher levels and incidence of this particular virus. And certainly I know Dr. Saulsbury has seen, we're not even talking about the pre-comorbidities that exist within Black populations that further exacerbates when you contract a virus like COVID-19. I don't want to get in front of the horse too much, but I could not agree more, Dr. Williams. Thank you very much.
Thank you.
Dr. Ward, Dr. Saulsbury?
I just wanted to say there was a young lady who worked for a grocery store with a disability whose mother was on the news just today talking about her daughter's dedication to the work because she wanted to help support the elderly individuals in her community. She thought, this was purpose work for her. Yeah. At the grocery store, right, on the front lines. In her mother's opinion, in everyone's opinion, what she was doing really was a challenge because she was not provided protection in the ways that you would consider that we are now thinking about it. And the one thing that they did mention, to Dr. Williams' point, is that her check for that work was $20. So in terms of thinking about economics and income and things like that, just realizing the work that we're doing, the significance of the work in relation to the actual, the price that we pay for the things that we're doing, and what are we doing to really support that. So there are tons of things going out around right now about, the grocery store clerks and just, frontline folks are out there doing the jobs and exposing themselves to the public for what little they make and how that's important in this conversation.
And Dr. Saulsbury, I know you want to make a point. If I could get everyone to put their city and state in the chat, I want to have an idea of where everyone is. So if you don't mind, if you could put your city and state in the chat, and we'd really appreciate that. Dr. Saulsbury, please.
Yeah, Dr. Williams eloquently talked about the economic disadvantage that we as Black Americans have always been at, and something that's not anything new. Unfortunately, whenever there is a new disease that's introduced into America or the world, Black Americans, African Americans, we are always disproportionately affected. You can go back to the early 80s, late 80s, when we had the introduction of HIV. It decimated the Black community as we knew it at that time. People were trying to say that this was related to your sexual orientation, but we quickly found out that that was not the case. So again, I'm not going to waste any more time, but the comorbidities that we as Black Americans have, diabetes, asthma, cardiovascular disease, rheumatoid arthritis, cancers, that puts us at risk. And I would say this, I hate to say it, but if you look at this, when the numbers, and Dr. Triplett probably knows this better than anybody, when we go back and look at the numbers of the number of Black people that are affected, I would like to see the economic relationship to those people, because as Dr. Williams said, it affects us so much in a negative way.
Wow. Well, all right, audience, participants, you've heard from this esteemed panel and some powerful comments that they've made and that they have set up what's going to be a very engaging and interactive conversation. So it is at this point that we want to honor what this is all about, is being able to allow you to interact with these panelists here. They are here giving of their time. Everybody's volunteering, including yours truly. And it's only because we know this is what is needed for the community, and we don't mind doing what we do. So with that, if you can raise your hand, I will unmute you, and there should be a wave icon, or if you don't see a wave icon down there, if you can wave your hand and I can acknowledge you, or if you'd like to put your comment in the chat, I could read it aloud for everyone. So is there anyone with a question or a concern to start off our dialogue?
Now, don't be shy. Come on, guys. Entertain us.
Okay, Ms. Jordan.
Well, I don't have a question. I just want to thank you because, Mr. Williams, because thank you for bringing this up. This is a much needed conversation. And sometimes we don't know how to have these conversations, but it's needed. So I appreciate that.
Thank you so much. Okay. Another comment or a question? Let me ask the panelists then, since everybody's being shy. Since this is somewhat a clinical question, what's come up as of late is 6 feet. There are those who are saying that 10 feet really need to be the sort of physical distancing that we need to have. So does it make a difference, 10 feet, 6 feet, in our interactions with each other? And then in doing so, which is what was brought up 2 nights ago, of course, we interviewed Ruben Warren at Tuskegee University, and how social distancing is leading to social isolation, which is leading into some mental health issues. So again, as we talk about whether 6 feet will be enough, and now we're talking about possibly 10 feet, how is that going to play out in community as far as our interactions with one another, and will that give us more mental health issues? Dr. Williams, seems like we have a point.
No, I mean, I'm happy to talk to that. I think 6 feet is now the recommendation. I would say it's the best estimate given the science. COVID-19 is new, and we are still learning a lot about the science. So I don't think we know everything that we would like to know. But this is what we know. We know that the virus, we can catch it, is transmitted from droplets when we speak, when we breathe. And I like to tell people when I talk about the virus to stand in front of your mirror and breathe. And you'll see some mist on the front of the mirror. And that's the way the virus can be spread. So what the evidence is that if someone stands within 6 feet of another, especially if it's in relatively close space, even if you didn't touch that person or you talk to them, but you are in that person's presence within 6 feet for about 10 minutes, you could catch, if that person has the coronavirus, you could get it from that person. The amount of space is needed is in part linked to whether you are in open space. If you're outdoor and there's a good breeze and it's open space, you probably don't need to be 6 feet. You know what I'm saying? But I think 6 feet is a good ballpark number. I think the key point is for all of us, we need to do everything we can, not only to protect ourselves, but to protect others. And it's an absolute essential idea in terms of trying to reduce the spread of the virus.
Dr. Weaver, let me just piggyback real quick on Dr. Williams' assessment of the 6 feet. This number actually came from the initial reports that we had out of Wuhan, China, in terms of how they determined how this was spreading at the time. To his point, you know, speaking and touching someone was how this actually came about. So with the initial studies, they did actually have looking at how someone actually forcibly coughs and respiratory droplets actually spread throughout the air. And they extrapolated the actual numbers to come up with 6 feet. So to your point, I don't know where we are in terms of 10 feet, but that's how we arrived at 6 feet. And obviously, this is a very fluid dynamic at this point. So this could easily change in the next several weeks. But at the end of the day, the thing that scares me right now, working in urgent care, is that I have asthmatics that come to see me and they need a breathing treatment. So that breathing treatment becomes aerosolization. That means that the droplets that they're breathing in is actually exhaled back into the room. We do not have non-pressurized rooms in urgent care. That's only in the hospital setting. So when we give somebody a breathing treatment now, we actually have to shut that room down for about 1.5 to 2 hours because of the fear of aerosolization. One of the reasons why you see a lot of patients actually being put on ventilators in the hospital is to reduce the amount of aerosolization that are in the hospital settings and ER settings.
I wanted to come back to the other question you raised, Dr. Weaver. You'd asked about the mental health, potential mental health impacts. And what I would say is that social distance, which is a good idea, does not mean emotional distance. And so we still need to find ways to connect with others and to reach out and touch others, especially many of the elderly who are staying indoors all of the time, that we can reach out with. We can use the telephone, we can use social media to still be in touch. In my own work, I chair a department, and everybody is working from home. We all working remotely. And for some of my staff, it's much more difficult than I thought it would be. Not so much for the faculty, we work from home sometime anyhow, but for some of the staff, it's really very difficult. You know, some are single, live in an apartment by themselves, and they are locked. It's a nice thing for them to have gotten up in the morning and get out and go to work and interact with others, and now they are stuck at home all the time. So I do think we need to think of the mental health impact, and we do need to think at a community level how we can organize teams and groups and churches and others to reach out to many in our community. We can still be in touch with them emotionally, even if we are keeping our distance for their own safety.
Dr. Triplett?
I would definitely agree. A lot of the work that you see in public health and community-based approaches to improving health, we talk a lot about trauma-informed care. And you hear that a lot now. And you consider just the change that everybody has had to endure or make in a very short period of time. This certainly can be quantified or categorized as a traumatic experience, if not for adults, then certainly for children. And so continue in this process and work it. We have all had a shared trauma. So now we've got to figure out not only how we can make sense of what happened, but how we can move forward through what has happened. And certainly mental health is going to be impacted. And certainly that's the least that we should not be impacted as much, because it's the most undiagnosed condition that we have. So we will have several people who will not out of this process the same way that we came into it. And so we have to be mindful of that as well. I would agree. Absolutely.
I have a question here from Commissioner Clyburn out of Washington, D.C. He asked the question, how will the rural community be impacted, particularly when there is not widespread testing? how important is it to have funding for our rural community health centers? So we're looking at rural populations.
Dr. Weaver?
Mhm.
Dr. Williams?
Yeah.
Dr. Williams, and then Dr. Saulsbury, then Dr. Triplett.
Oh, okay. I would say I am concerned about rural populations. You're correct. The rates of testing are very low, but in rural populations in recent years, we've also had the closure of a lot of hospitals. So many people in rural areas have less access to healthcare. They are further away from a hospital than, let's say, 7 to 10 years ago, because the number of rural hospitals that just haven't found it financially viable to remain open. So it is a problem. On the one hand, hopefully, maybe there's a lot of social distancing that happens naturally. In some rural communities, people are further spread out, so we're not as concentrated and riding on public transportation together on the one hand. So those things might reduce the risk of transmission on the one hand, but on the other hand, the availability of care in many rural communities is becoming a major challenge in the US.
Dr. Saulsbury, Dr. Triplett.
Yeah, just for case, just here in Georgia, Dorothy County, Albany, right now they had some of the largest confirmed cases as well as deaths, all within the last 3 to 4 weeks. That community, to Dr. Williams' point, the rural hospitals here in in Georgia have been exponentially closed over the last 5 to 10 years. So their resources, their ERs, their ICUs are not up to par to actually be able to take on such illness as COVID-19. In some rural areas, you may have maybe 6 ICU beds compared to somewhere like a healthcare system like a WellStar, who has well over 50 ICU beds, usually on several different floors, spread out over the hospital system. So that concerns me, because now you look at a population that's smaller, but now they're more vulnerable to COVID-19 in the resources. So you have less staff, less doctors, less nurses, less EMTs. So these people are having to be taken to places like Atlanta, Macon, or Savannah.
I would just agree with what both Dr. Williams and Dr. Saulsbury have stated. When we talk about rural community, that is often the issue, only proximity, but access to quality care, which is another qualifier that we must use when we're talking about access to care. There's access to care and to quality care. And then to Dr. Saul's point, it has everything to do with what you can access. What kind of services are you accessible to? And certainly in rural populations, the ratio of clinicians to populations is often very, very low, for exactly what Dr. Williams and Dr. Saulsbury have stated. So rural populations, as with many other chronic and infectious conditions, are going to bear the brunt of exactly what we've talked about. But my prayers are with them, because they are not as closely packed as we would say in an urban population or urban setting.
And I want to just bring up a point too about rural communities, because we are talking about either, with the virus spreading so quickly, we are going to spread the people so that the virus doesn't spread. And a lot of people are starting to get that. And so I have there are very many people who assume, well, I'm in a rural community, so I have more space. And so it's a false sense of protection. Once again, we're talking about intersectionality. So we have people, Black folks, poor folks, rural communities that are resource poor. You're talking about politics. All of these things are compounded. And then you add to that this idea that, so if I'm physically distant from other people, then I should be okay. But someone asked about Talladega, Alabama. I'm doing some work with Tuskegee University with the Black Belt counties in Alabama, just looking to make sure that we are able to follow everything as it comes out. Chambers County is a county in Alabama, 129 folks, you know, with COVID-19. I think they tested somewhere like 180. And the resources in that small county are literally, their numbers are higher than Montgomery County, Montgomery, Alabama. And you're talking about just up under Madison County and Jefferson County. So that's Birmingham, Alabama, you know, Mobile, Alabama. These were places where you would expect to see those numbers in the raw data. Looking at those numbers just alone, you don't have to do much calculation there, because if you know anything about those places in Alabama, you know that that is alarming. And so when we start talking to people, and I'm always talking about health communication and health literacy, understanding what they're getting from our messaging. A lot of people have said to me, well, I live in this small town. We don't have a lot of numbers. So it's not possible that this would impact me like it would have happened in Montgomery, Alabama, for instance, or a Chicago or a New York. And that's just not true. And one of the things I had to point out yesterday was that most people who are living in these rural counties, they still work in neighboring counties or neighboring cities. And so the idea that you're not in contact with the virus in any way, or you grocery shop in those places, you know. So I had to really bring it back to just the context in which they live versus thinking about it from this tagline, you know, social distancing. Oh, I don't live next to anyone. And that's important as well.
And I think that is the beauty of this conversation, that we can look at both urban areas as well as rural populations. So I appreciate all the panelists for bringing that conversation to the fore. And thank you, Commissioner Clyburn, for asking that question, because you see that it was very productive. We have a sort of somewhat of a hands-on question here. We have Keith Mosley, who asked the questions. There's been talk about how long the virus can thrive on various surfaces. Now check this question out. Should I wear protective gloves when searching for graduation greeting cards?
Yes. Yes.
Yes.
Last week, I was able to share with the audience that the studies that have come out now, whether it be from China, Italy, or here just in the States, that there are several ways that this is actually being transmitted. First and foremost, actually respiratory droplets, sneezing, coughing, things of that nature. But also when those droplets are dispersed into the environment, they can get on a countertop. Okay, they can get on a gas pump handle. They can get on the actual card he's talking about in a grocery store. Right now, the half-life, the minimum right now, anywhere from several minutes on certain surfaces to actually several hours, even several days on other surfaces. So to this person's point, I would definitely recommend to wear gloves going out in public and touching things. I know that in some of the local grocery stores, they're actually wiping down the actual handles on the carts. But I would be remiss to tell you, I wouldn't trust that, honestly. I would have gloves as well as a mask.
I do have a question for you, Dr. Saulsbury, because that's a good point. I know that in talking with people about the use of gloves, part of the idea of things being able to stick to gloves, you know, as you start to move around, you don't change your gloves, you don't wash your gloves. Not having gloves might be a better way to go about it, but what you're saying makes sense. My only question, though, is how do we follow up with that statement about wearing gloves in terms of how to properly dispose of the gloves? You know, if you're wearing gloves to pump the gas, you don't get back in your car with the gloves on and go and touch the steering wheel, and then you take the gloves off and the gloves are on the, you know, so we have to make sure that people understand. And even with the mask, we have a lot of, you know, the process of all of this for us, you know, if you are not in your position, we want to, you know, how do you do that? So can you give us some information about that part?
Yeah, great question, Dr. Ward. I would tell you this, that, you know, depending on where you go, when you use gloves out in public, I know that, you know, there was a talk about shortages and things like that leading up to here, but I would tell you it's probably still a one-time use. So if you go to the local grocery store and you shop, and once you leave, you take those gloves off before you touch the handle on your car or get into your car and touch the steering wheel. That means that, well, some people will have to bring more gloves. Well, at the end of the day, I think you err on caution. And as far as taking gloves off, it's real simple. You just take them off one side, then take the other side off and encapsulate both of them and throw them and discard them away. It's real easy.
Thank you.
Okay, wonderful. Dr. Triplett, you want to make a point before we move on to the next comment or question?
Oh, no, I'm getting excited. You're absolutely right. These are the questions that people ask in day to day. And certainly in public profession, we have here to respond to these questions. So thank you so much, Dr. Saulsbury. And I'm so glad that you said you. I could tell you what that's almost like, but I'm going to leave it PG in here. I'm not going to R-rate yet.
Not yet, not yet. Okay, well, let's quickly.
Not yet.
Not yet. I'm being mindful of the time. We have 15 minutes. We started promptly at 7. We're going to end promptly at 8. And we also want to give the panelists some time for some closing remarks. Have a comment here from a third-year medical student down in New Orleans, and she has a pretty long comment. But the question she has at the end is, as a medical Black student, and pretty much the only Black voice in my year, she's a third-year medical student, how can I address these issues? Talk about environmental racism, economic disparity, as well as healthcare inequality within both the local and the healthcare community here in New Orleans.
Can I say something really quick about that? I had a call yesterday with students from Black ladies in public health and Black men in public health. And I asked the question about how many of them think they can actually speak on a panel to their peers about the issues that are going on with COVID-19. And one of the things that, well, no one said they felt comfortable enough to do that, first of all. And these are students from junior to PhD level students. But one of the things that stood out to me was that in thinking about preparing students for this conversation, one young lady who's from Toronto said it's off message. It's off brand, because when you start to talk about race in the context of this issue, paired with our alone together message, it really does not add to, she doesn't feel empowered, or she doesn't understand just how do you navigate that. So she stays away from it because, again, we're talking about alone together, and this is something that doesn't discriminate. And we're putting this out there. How is she supposed to move forward? So I would love to hear context and not just what the student wrote, but thinking about preparing students to do this work with their peers and people around them.
Well, I'll take that question, the medical student. You know, the National Medical Association has always been the voice of Black physicians and surgeons in this country for well over 75 years. They do have a student section of the National Medical Association, SNMA. And so when you look at where this is going, I know institutions like Howard University Medical School, Meharry Medical College, my alma mater, Morehouse School of Medicine, as well as Drew College of Medicine in LA, they will be addressing these issues. I saw a question earlier about how can we get the numbers of the number of Black people that have been affected by COVID-19. I do know that there is a push right now on a national level to get that information. I don't know how quickly we can get that information, but I know that the CDC is putting that point well forward. As far as the young lady is concerned, contact the local National Medical Association chapter in New Orleans. They definitely have a state chapter as well as a regional chapter. You can reach out to the presidents and the secretary of those organizations, and they can actually help you with that.
Let me jump in. We have 11 minutes remaining. Anyone who wants to get on the email list, make sure you send me an email either through the chat, or I just forwarded my contact information so you can get notices on what we're going on. For all the panelists, if you have websites, please put your website up so that everyone would be able to get in contact with you as well. Dr. Ward, did you want to make another point? Did you have your hand up? No?
No, I just typed, I said I have data for 14. I was able to find state data for 14 states, but I'm not, the CDC only put out a small number of people in the study that they recently released. So.
Yes, Dr. Triplett,
Let me
please.
just make a quick point. As leaders, each of us has a responsibility to understand that no position, vacuum, individual in a vacuum. People are complex entities. They come with all the baggage they come with, whether it's race, whether it's ethnicity, whether it's immigration status, whether it's age, whatever it is. Now, as a physician and clinician, you cannot disconnect the individual from the condition that you're speaking in. So at the third year level, this is as good a time as any to understand that you are going to not only be able to dispense medicine, and when you take that oath, to do no harm means you also must advocate on behalf of the clients that you are responsible to see. So if you don't have the communication skills now, if you don't feel empowered, we need to get that skill and competency in place, because it is just as much a part of the work that we are here to do as the medicine that you dispense. It's got to be a part of your toolkit.
Dr. Williams?
Yeah, no, I agree that I would say to young students in any discipline that the key is to get informed. Try to get reliable sources, learn about it so that you know the facts and you can share the facts. I mean, I like to think of the opportunities that I have in life and think that people give their lives and sacrifice to open the doors that I'm able to walk through. So it's not just about me. It's about how I can continue the struggle and how I can make a difference for those who are coming behind me. So I would encourage young people, be informed, and yes, try when you have opportunity to have an impact. Many audiences are not aware of the facts. Try to have your act together so what you say is absolutely accurate, but you can raise it. And the other point for all of us, we all need to work together, and I say we as a society, as a community, to increase the density of African Americans and people of color in medical and health professional schools. There was a report from the American Association of Medical Colleges in 2014 that there were fewer Black males of medical school in 2014 than in 1978, and that's not good enough. We need to have greater representation in medicine and all of the other health professionals as we move forward. Because who is in the room and who sits around the table, and the knowledge they bring matters profoundly for what happens.
Matters profoundly. Wonderful. We have another question here, a very practical question. Then afterwards, we're going to have the panelists to go around and get some closing comments. We're at 7:53. We shut it down at 8 o'clock promptly. The question is it safe to eat takeout from restaurants? It's got to ask.
Yeah, it's safe. I mean, I think at the end of the day, you need to practice just good hygiene. Wipe the box down or whether the item has been delivered is. I will tell you this, that if you have any item that's delivered that has a seal that's been broken, discard it quickly. I mean, I was never really a big fan of Uber Eats or things like that, even before this. So personally, I'm a little leery. I think I've grilled out in the past 3 to 4 weeks more than I had all of last summer. For those who can, just remember, practice good hygiene when wiping those packages down.
Anybody else want to add to that?
Take it out of the box, place it on a real plate from your house, discard the box, and then eat like that. But I agree, you're gonna have to use personal hygiene at its highest levels in order to be comfortable with that.
I would want to just point everyone to a resource. If you Google nutrition resource at Harvard University, nutrition resource, it's at my school, the Department of Nutrition has a resource with a lot of information on nutrition. There's a wonderful article on there of how we can be safe when shopping and eating out. So I would say Google nutrition resource Harvard. That will come up, and look for the entry on shopping and going to the supermarket in the era of COVID.
All right, thank you so much. And again, we're going to go around to the panelists at 7:54. I want to thank all the participants again. Shout out your city, let us know where you are. Please send your email address so we can have you on the email blast. I also put the information down for this coming Tuesday. We have another panel on Tuesday. We will have gay rights activist advocate Damian Lima. We will have OBGYN Dr. Tracy Nelson, who I see is online with us right now. We also will have Dr. Helen Moore, who's a family physician, and we'll have a return of Dr. Italo Brown, who's an emergency physician at Stanford University. So again, make sure that we have your email address so we can reach you. Let us know your city, let us know your state. We're going to go ahead and start closing things out. We have 5 minutes. Dr. Triplett, do you mind giving us some closing remarks?
Here's the thing that I had an interview just last week, and the question was, when are we going to return back to normal? And my statement was very plain. What has been shall not be again. What is to be is up to us. We have an opportunity right now to create our new normal. Take this opportunity and be great. That's my last statement.
Right. Dr. Saulsbury, please.
I'd like to piggyback on what Dr. Triplett said. The question is, when will we get back to some sense of normalcy? Right now, I would just tell people, let's continue to practice social distancing. I saw a comment earlier when I was talking about gloves, and one of the guests said, just stay at home. I mean, that person was absolutely spot on. But I know that people have cabin fever and you want to get out. Just try to limit your interaction with people. There is good news coming out of New York right now that some of the numbers are starting to appear to be flattening. Yeah. I know in California that has been the case based on some of the recent numbers I saw from the CDC as well as Washington State. So I believe that if we can continue this push of social distancing, even into the early part of the summer, middle part of the summer, hopefully we can get back to some sense of normalcy, hopefully at the end of the summer, first of the fall.
Dr. Ward?
Sure. I would like to just, there are a couple of points that I want to make. In terms of working in our communities, we have to really think about how we prepare folks around us to really speak for us in ways that is accurate. Like when Dr. Williams was mentioning that it is based on the science and based on things, but also based on context in which people are living and working and trying to survive. So we have to be willing to, I always say, have a little grace in this work and talk about the fact that, yes, we want you to stay home. If you have to go to work, we then, as public health professionals, those of us who understand and are connected to public health people, can think of ways, innovative ways to help them survive out here doing the work that they're doing, because we're not centering everyone in this conversation as we talk about this in the masses. So we have to be willing to do that and understand that every voice counts. So even if you don't think that you have the expertise to necessarily do it, speak from the heart and tell people you care about them, because that is proven to be way more impactful than understanding, how droplets are affecting people and things, being able to speak from that perspective. Also just thinking about where we stand in intersections of politics right now and things of that nature. When people start to say, well, Black people are more susceptible to COVID-19, speak about the ideas that we know are true as it relates, not even the ideas, but the truth as it relates to systemic racism and things that have happened that have marginalized communities, not just Black people, but anyone who stands in the margins, and understand that until we address that, we will not be able to see any difference. We all knew what was going to happen with this data prior to even receiving it, unfortunately. But we have to be willing to do that and tie it into things like politics. Your city did one thing, someone else did another, because we have to make people see where the intersections of this and what we've been dealing with all this time as it relates to social justice issues and criminal justice reform, all of these things. Talk about it. And if you need help with it, find someone who is a public health professional or someone in that space who can assist you, but please don't be silent.
And Dr. Ward, we thank you so much for that. Dr. Williams, can you close it out? Well, Dr. Saulsbury, we got to be very quick. Yes.
It was a question from Derek Holland, one of the guests. He asked about how do we prevent this second wave since we don't have a vaccine just yet. I do know that there are several hospital systems, particularly here in Atlanta. Emory has already been given the green light by the FDA to come up and start treating with what they've had now for several years since H1N1 as well as SARS back in 2002. So I do know that they're trying to fast track some treatments. I know that antibodies have been the biggest topic thus far this week. People who have contracted disease and have come back with great results, they're taking those antibodies and infusing them, hoping to help add in the treatment diastrom as we go forward.
Thank you, Dr. Saulsbury. It is 8 o'clock. If everyone could give us 2 more minutes, and we'll let Dr. Williams close us out for the evening. Dr. Williams, please, the closing comments.
All right. I think as we look longer term, most Americans do not know, research tells us, that racial disparities in health exist. That's a surprise to us who are in the field, but that's what the data tells us. I think we need to take the moment where coronavirus has now educated the American public about racial disparities. We need to use that momentum to work with our policymakers to tackle the root causes of racial disparities. I'm talking about getting momentum for policies that would strengthen affordable housing, living wages, easy access to healthcare providers, access to healthy food, training to reduce implicit bias. All of these things need to be done. I think we can use this moment as a time to call us to fulfill the promise to all Americans so that these striking disparities that we see, we don't blame them on individuals, we don't blame them on families, we don't blame them on communities, but we understand the social policies that have created them, and we work to dismantle those social policies so that we can create a healthier future for all.
That's a word for us, ladies and gentlemen. We thank everyone. Thank you, Dr. Williams. Thank you, Dr. Triplett, Dr. Saulsbury, Dr. Ward. Thank all the participants for being here. We are 2 minutes over. Again, contact information has been given to everyone. Hopefully you'll join us again on Tuesday. Everyone have a very blessed evening, and I thank everyone for having attended. Goodbye.
Thank you.
Thank you. Thank you.
Mhm.